Hello, and welcome to another Think Thrombosis podcast from medthority.com. My name is Geoffrey Barnes. I'm a cardiologist and vascular medicine specialist at the University of Michigan in the United States. And on today's episode of our podcast, I am thrilled to be joined by Professor Tanja Potpara from Belgrade University, current president of the Serbian Atrial Fibrillation Association. Tanja, welcome to the podcast today.
Thank you. I'm excited to join you today.
I wanted to talk with you about a really important topic of anticoagulation for really our most common indication, which is atrial fibrillation. And that focuses on how we approach bleeding risk in patients who have atrial fibrillation. And I'm wondering, in your clinical practice, what is the approach that you take to estimate or identify certain bleeding risk factors in your patients as you start to think about different strategies for stroke prevention?
First of all, stroke is a devastating complication of atrial fibrillation, as it's often fatal or associated with significant permanent disability. So we have therapies that are effectively preventing stroke in patients with atrial fibrillation, and our patients should not be denied such effective therapies because of some concerns that can be managed other way. Assessing bleeding risk in each individual patient and balancing the risk of bleeding against the benefits of stroke prevention is mandatory in each individual patient with atrial fibrillation. How we can assess bleeding risk? Well, in general, there are two approaches that could be used in daily practice. One of the approaches is to just review modifiable bleeding risk factors. First of all, modifiables such as uncontrolled arterial hypertension, concomitant antiplatelet therapy or nonsteroidals, excessive alcohol intake, and so forth. And there is another way, which is probably more convenient for non-experts, and that is to use a structured approach using some of the clinical risk factor-based risk score for assessing bleeding risk. There are several such scores. Some of them have been tested more extensively than the others. And it is important to keep in mind that these scores are far from perfect. They perform only modestly, and their role is not exactly to identify patients who are going to experience bleeding events. They are should be used more to facilitate comprehensive review of non-modifiable and modifiable bleeding risk factor in individual patient, with the purpose to address modifiable bleeding risk factors and to flag up patients with non-modifiable bleeding risk factors such as advanced age or previous major bleeding or severe renal or hepatic impairment and malignancy and so on. And these patients with non-modifiable bleeding risk factors should be scheduled for a more frequent clinical follow-up and review of their therapy.
So you outlined for us nicely this approach of using a risk score, and we've seen many of these, things like the Hasbled score. There's also the Atria score and the hemorrhages score. And that can be a nice systematic way to walk through and identify both those modifiable and non-modifiable risk factors that you mentioned. I'm wondering if you could maybe compare and contrast for us a little bit about what the guidelines tell us we should do. I'm thinking about the European Society of Cardiology guidelines, as well as the North American guidelines from the ACC and AHA. How do they suggest we either do or do not use these different risk scores when approaching anticoagulation selection for patients with AFib?
It's essentially both guidelines emphasize bleeding risk assessment and balancing the two risks, risk of stroke against risk of bleeding in each patient. They emphasize that it is integral part of stroke risk management in patients with atrial fibrillation. But European guidelines further stress that using a structured clinical bleeding risk factor based score is recommended. It is class 2A recommendation because in several observational studies, comparison of the two approaches revealed that using a structured score has been associated with better patient outcomes, which is likely the consequence of a more comprehensive review and systematic review of bleeding risk factors in patients by responsible physician.
And I think importantly, the guidelines, especially the North American guidelines, really suggest that we should not use these scores to systematically exclude patients from receiving anticoagulation, but rather, as you say, as a guide to identify things that we could modify and lower their bleeding risk. But
And that is very important point because both guideline documents consistently emphasize that denying oral anticoagulant therapy solely based by the perceived bleeding risk in that given patient is not recommended.
So let me ask you this next question. When you have a patient who's coming to your clinic and you're talking with them about stroke risk reduction in atrial fibrillation, how do you use either one of these bleeding risk scores or maybe taking a history? Maybe it's your gestalt. How do you use it to decide amongst the different strategies for stroke prevention? I'm thinking about maybe the vitamin K antagonists like warfarin or the direct oral anticoagulants, our direct thrombin and factor 10A inhibitors, and then eventually even some non-medication approaches. How do you approach that decision making?
Well, the decision-making process is multifaceted indeed, and it includes not only the individual patient bleeding risk, but also concomitant comorbidities, patient personal values, preferences, then local healthcare system features, whether some options are available, reimbursed or not. In general, patients are there are very few true absolute contraindications to oral anticoagulant therapy. Oral anticoagulant therapy is highly effective and successfully prevent stroke in most of the patients with atrial fibrillation, whether it is a well-controlled vitamin K antagonist treatment or preferably direct oral anticoagulant therapy. Direct oral anticoagulants do have advantages in terms of easier daily use, fixed dosing, fewer drug-drug or drug-food interactions. But the most important advantage of these drugs is significantly reduced, more than a halved risk of the most severe bleeding complication, and that is intracranial hemorrhage. So oral anticoagulant therapy will not be contraindicated in most of the patients with atrial fibrillation. Where there is a true absolute contraindication, such as, for example, congenital coagulopathy or amyloid small vessel disease or recurrent bleeding events while using oral anticoagulant therapy, then there are non-pharmacological options that should be considered again through the process of shared decision making, and that would be percutaneous left atrial appendage occlusion. And appendage occlusion has been increasingly used in daily practice, not only in patients with absolute contraindications to oral anticoagulant therapy, but also in patients unwilling to take long-term, lifelong oral anticoagulant therapy.
So I'm wondering if you could maybe explore that a little bit more. You mentioned that there are very few patients who have these absolute contraindications to anticoagulation, but of course we do have those patients. And when we start to think about how best to reduce their stroke risk, what is some of the data around the efficacy of these left atrial appendage occluder devices? Are they good options? What's out there? How should we approach that conversation with our patient?
Well, the general concern when making a formal recommendations for considering a left atrial appendage occlusion is that um, we are still missing a sufficient amount of high quality data to support why the use of left atrial appendage occlusion. We have only a few randomized clinical trials comparing, and those trials are conducted among patients without contraindications to oral anticoagulant therapy and mostly compared left atrial appendage occlusion versus warfarin. There is one small completed trial comparing occlusion of left atrial appendage versus a DOAC, but a totality of high quality randomized data is regarded insufficient to provide formal recommendations beyond considering of left atrial appendage occlusion when there is an absolute contraindication for oral anticoagulant therapy. However, in daily practice, patients' preferences may lead to choice. And there are also patients with recurrent bleeding whilst using oral anticoagulant therapy, or patients in whom, for example, the source of GI bleeding or urinary bleeding is intractable or cannot be effectively managed, and all these, or patients with severe liver dysfunction or end-stage renal disease. And in most of these patients, there is a sufficiently high risk of stroke that calls for some stroke prevention therapy. And these are all circumstances when left atrial appendage occlusion should be considered. And there are also several ongoing randomized trials that could be broadly classified into two main groups. First, testing left atrial appendage occlusion against best medical care in AF patients at high risk of bleeding. And these are patients with a Hasbled score or more than 3, or patients with a history of intracranial bleeding, patients with end-stage kidney disease, patients with a high CHEST score and absolute contraindication to oral anticoagulant therapy. This is the first group of randomized trials, such as, for example, closure, AF, stroke, close, clearance, and so forth. And there is another group of ongoing trials, and these are large-scale trials testing left atrial appendage occlusion against a DOAC. So it is these trials are expected to provide sufficient high-quality evidence to guide optimal use of left atrial appendage occlusion in patients with AF who are unable or unwilling to use oral anticoagulant therapy.
You know, you talked about these ongoing trials exploring the role of the left atrial appendage occlusion device. That makes me think of some other ongoing trials of a new class of anticoagulant, the factor 11A inhibitors. And I'm wondering what your thoughts are on the potential future of having a new class of anticoagulants that in theory, could have less bleeding than our existing drugs, the direct oral anticoagulants.
Well, we are still in search for a holy grail of oral anticoagulant therapy. Ideally, we need a drug that will spare hemostasis and attack, pathological coagulation. We still do not have such a drug. And it is hoped that this new class of anticoagulants, direct factor 11A inhibitors, would be, as you said, would be associated with significantly less bleeding, would be safer, and at least as effective as currently available drugs. And if that would be a case, then we would have even safer oral anticoagulant therapy in hand, and management of high-risk subset of patients with AF would improve such way. But the phase 3 randomized trials are ongoing, and there is still several years to go before we have first relevant information.
You know, as you mentioned early in this podcast, there are very few patients who have a true absolute contraindication to anticoagulation. And you talked about the use of those bleeding risk scores, often to identify modifiable bleeding risk factors. I'm wondering if you could talk for a minute about how you use those in practice. You mentioned things like uncontrolled hypertension, concurrent use of antiplatelets and NSAID medications. How do you go about addressing some of those concerns when you have a patient with atrial fibrillation in whom you want to prescribe an oral anticoagulant?
It needs to be, first of all, these factors need to be carefully reviewed, and the patient has to be informed about the importance of controlling these factors. Some of some of these factors can be controlled without patient input. For example, we are the ones to improve hypertension treatment, to control hypertension, and to shorten the combined therapy with antiplatelet drugs, to shorten it as much as possible. But on the other hand, patients need to be informed about the risks associated with use of non-steroidal anti-inflammatory drugs without being prescribed. Also, they have to be informed that excessive alcohol intake would impact their bleeding risk. It's also important to increase the patient's awareness about importance of adherence to oral anticoagulant therapy. And it is very important to educate patients so that patient understands the importance of patients need to actively approach management of their bleeding risk. And it's only the collaboration between physician and patient that will result in reducing the risk of bleeding. And there is one important point that I would like to emphasize. Bleeding risk assessment is not one-time procedure and then prescription of OAC and patient is off to go. A bleeding risk assessment is dynamic. It changes over time, increases with acquiring of new additional bleeding risk factors. So it needs to be regularly reassessed, ideally at every patient visit. And it is actually the change in the bleeding risk factor that is predictive of a bleeding event more than a baseline patient bleeding risk score value, for example. So patients need to be reviewed and their bleeding risk needs to be reassessed at every clinical visit.
Well, this has been just such a wonderful conversation around the role of bleeding risk for our patients with atrial fibrillation. A few take-home points that I'm reflecting on is that you really highlighted the importance to balance stroke risk against bleeding risk for each individual patient, and that sometimes we can approach this by looking at modifiable bleeding risk factors. You've mentioned hypertension, antiplatelet and NSAID meds, excessive alcohol use, but also through the use of these scoring systems like the HAS-BLOOD score to be systematic, and that structured approach can also often be useful for clinicians. You also reminded us that there are very few patients who have an absolute contraindication to anticoagulation, but when that's the case, we can then look to other strategies such as percutaneous left atrial appendage occlusion. And although you cautioned us that the existing trials maybe aren't necessarily in the population we think of, but there are ongoing trials looking at this use in these high bleeding risk patients, which is very exciting. We also talked about this emerging field of factor 11A inhibitors and whether or not they're going to reach that holy grail of being able to prevent thrombosis while not inhibiting hemostasis. And we'll have to see what happens. And then, of course, you left us with such an important final point, which is that bleeding risk is not a one-time and done assessment. This is something that's dynamic and needs to happen over and over and over again. And I know that's a really important point I'm going to bring back every time I see my patients in clinic, continually reassessing the bleeding risk and having those conversations with them about how we can reduce their bleeding risk so they can remain on their anticoagulant and maximize that stroke preventative strategy. Anything else you want to add to that summary?
Well, just to reiterate that bleeding risk assessment is mandatory, but it has to be conducted reasonably and responsibly. And bleeding risk in itself should not be the reason to deny oral anticoagulant therapy in patients with AF at high risk of stroke.
Well, Professor Tatjana Potpara, thank you so much for joining us today. And to all our listeners here on the Think Thrombosis podcast from med30.com, I hope this was as informative for you as it was for me. And I look forward to seeing you on another one of our podcast episodes.
Thank you.